Hi, this is Becky Weiser. Good morning and welcome to yet another online medical event, which I'm sure we've all had plenty of. We're lucky enough to have Dr. Diaz, who's basically a world-famous pediatric neurosurgeon, who we've invited here today to talk to us about a neurosurgeon's approach to the abusive head trauma. Dr. Diaz has a lifelong dedication to the evaluation, treatment, and research regarding abusive head trauma. He has won many, many awards, and some of which I think are wonderful for being patient's favorite award. So he's a wonderful person who's done lots of work and will have lots of information to give us today. So we welcome you and thank you so much for agreeing to this difficult process. Dr. Diaz, welcome.
Thank you. And I'm truly honored to be able to do this. I wish I could do it there. I was really looking forward to coming to Seattle with my wife and spending a few days there, but we'll just have to come some other time. So today's talk is called Abusive Head Trauma, Concepts, Controversies, and Conspiracy Theories. Hopefully I'll get to the conspiracy theories at the end of the talk. So just to bring us all up to speed on the components of abusive head trauma, it involves some sort of intracranial hemorrhage, which is subdural, which is present in about 80% of cases, much more so than subarachnoid, greater than intracerebral hemorrhage, greater than epidural hemorrhage. The subdural hemorrhages are most commonly interhemispheric and tentorial in location. The second component is some sort of brain injury. And I should say that not all of these need be present in any particular case, but the second component is some sort of brain injury, which is more commonly posterior temporal occipital in location. Nobody really knows exactly why. The third component is some sort of retinal hemorrhages, and we'll talk about those in greater detail. Again, about 80% of cases have retinal hemorrhages on average. And then variably, either rib or long bone fractures, posterior or lateral rib fractures, most commonly, and metaphyseal long bone fractures. And then I added this in yellow here, ligamentous neck and or spinal cord injuries. Sorry, somebody's asking to annotate. Ligamentous neck and or spinal cord injuries, which we now know are present in about 30 to 80% of these. A number of clinical predictors of abusive head trauma. There have been many, many papers published about this. The one I like the most, I think, is Sabine McGuire and Alison Kemp's paper in Pediatrics in 2011. This is sort of a meta-analysis of clinical features of both abusive and non-abusive head trauma. They found 14 high-quality comparative studies. 9 studies of that 14 encompassed the majority of the patients, and 6 studies provided individual level data on which they could get the data in over 1,000 children less than 3 years, 350 or so with abusive head trauma and 705 without. And what they found was there were 6 clinical features that correlate nicely with abusive head trauma. Intracranial injury associated with apnea, retinal hemorrhages, rib, skull, and or long bone fractures, seizures, and head and or neck bruising. And if you look at the table on the right, it's obviously very small and very complicated, but they did an analysis of all combinations of these 6 different things. And what you note is that any combination of 3 or more of these yield an odds ratio greater than 100 and a positive predictive value of greater than 85% of abusive head trauma. And you can see down at the bottom of this slide, when you get down to 5 and 6, the value is incredibly high. Neuroimaging is a cardinal feature of abusive head trauma, and I'm just going to go through a couple slides here just to orient you. These are the typical findings on this initial CT scan. You can see a subdural hemorrhage here in the interhemispheric fissure and along the posterior pole of the occipital lobe. There's also a little bit of hemorrhage over on the left parieto-occipital area. And this is the follow-up CT scan, which shows a massive loss of brain substance, massive atrophy with very large ex vacuo subdural collections. And you can actually see rebleeding this hyperdense area posteriorly within the subdural. if you look back on the initial CT scan, you can see there's a loss of gray-white differentiation, particularly, again, posteriorly in the temporal, parietal, and occipital lobes. On this slide showing these are different sequences on MRI, and you can see that blood looks different on the different sequences. You can, for example, look at this little subdural hemorrhage around the right posterior occipital pole here and see how it differs on the various imaging sequences. So MRI gives us a lot more views of the hemorrhage. One of the most important findings on MRI and sequences are the diffusion and the ADC map, the corresponding diffusion coefficient map. And you can see on this scan that there are changes posteriorly and deep in the basal ganglia in this child in the left hemisphere. It's important because these indicate cytotoxic edema, which supports this ischemic injury that we see in children with abusive head trauma, something I'll talk about in just a second. At the extreme, we get what's called the reversal sign. This is a nice example where the cortex and the underlying subcortical white matter are completely hypodense compared with the basal ganglia and thalamus, which usually it's the other way around. And then in this scan here, of course, we have sort of diffuse loss of gray-white differentiation, hypodensities involving virtually the entire brain, along with the mixed density subdural here, a hypodense component on the right with a little hyperdense component within it. And on the left, we see also a hypodense component. Also, if you look carefully along the posterior falx, you'll see hyperdense blood along the interhemispheric fissure on the left. This is what a reversal sign looks like on an MRI scan. You can see again the sort of change in the characteristics both on T1 and T2 weighted images. And then, of course, we have children who have chronic or mixed density subdural hematomas or mixed intensity on MRI. And these are just two nice examples showing that. And you can see the subarachnoid space with the cerebrospinal fluid here following closely along the cortex with the overlying chronic subdural hematoma here. And you can see the difference in the intensity between left and right sides in the image on the left. Retinal hemorrhages, as I said, average about 80% of cases of abusive head trauma. They may be predominantly or even strictly unilateral in up to 50% of cases. They usually, but not always, are associated with intracranial hemorrhage. There's a few percent of abusive head trauma cases where you can get retinal hemorrhages without visible intracranial injury. And they are pretty specific in general for abusive head trauma. If you look at all accidental head trauma, somewhere around 3 to 5%, some studies maybe up to 10% may have some retinal hemorrhages, and we'll talk about some specific cases where that occurs. But in almost all of the cases of accidental head trauma, the mechanism of injury is obvious, and the hemorrhages are few, generally speaking, and limited to the posterior pole. We look at retinal hemorrhages, there are a number of different types. And so just to bring us up to speed, of course, there's vitreous hemorrhage, which is listed, you can see in the illustration on the right here. Vitreous hemorrhage occurs in the vitreous, of course. There is pre-retinal hemorrhages, which are hemorrhages that are in front of the retina, and the vessels which are running under that layer are obscured by the hemorrhage. Intraretinal hemorrhages include dot, blot, or flame hemorrhages, and you can see a number of those on this illustration here. Those are the obvious ones that we typically see. Subretinal hemorrhages are those that are beneath the retina, and the blood vessels are visible over the top of the hemorrhages. So this, for example, here is a subretinal hemorrhage on this illustration with the blood vessel crossing over the top. Retinoschisis, which represents a separation within the retinal layers, not a retinal detachment, but actually a split within the retinal layers themselves, is present in about 23% of the cases. Now, if you go from top to bottom here, you start to get more specific for abusive head trauma. So in terms of specificity, you can go from the top image on the right here, where there's just a few dot, blot, flame hemorrhages. That's really pretty non-specific. and not particularly specific for abusive head trauma. Hemorrhages that are in multiple retinal layers, like the middle illustration here, that are pre-retinal, intraretinal, and subretinal, are more specific. Hemorrhages that extend out along the vascular arcades in particular and extend out to the edges of the retina, which is also called the ora serrata, are increasingly specific for abusive head trauma. And then traumatic retinoschisis, which is in the image here on the lower right, is the most specific for abusive head trauma. And it's really seen otherwise only in, it's only been reported in severe motor vehicle crashes and a few crush injuries, where the head basically is cracked in multiple places from something having fallen on the head. So I want to talk about abusive head trauma from a historical perspective for a minute. Guth, Kelch, and Caffey in 1974 each described what they call the infant shaken whiplash syndrome initially, but shaken baby syndrome was the moniker that was applied to it relatively early on. Tina Duhaime, a pediatric neurosurgeon then at Philadelphia in 1978, pointed out the important role of impact in this and coined the term shaken impact syndrome. In the 1980s, there was increasing evidence from a number of studies showing impact in somewhere between 20 and about 2/3 of these patients, even in those in whom shaking only was described by the perpetrator, if there was a confession. And this has led in the 1990s to somewhat of a backlash against shaking as a potential mechanism of injury. In the 2000s, that gained steam. Shaken baby syndrome is a myth based upon inadequate or false science. And then in the 2010s, we're seeing multiple cases of individuals who are seeking post-conviction relief. And this has become the next Innocence Project. So what about the biomechanics of abusive head trauma? Well, I want to go through that a little bit to explain to you why it doesn't really show that shaking is inadequate to produce these injuries. So we start with a group of researchers, Generelli, Thibault, Amaya, again at Penn, in the 1970s. And they used adult monkeys who were placed on sleds, and the sled had a piston that threw them forward very, very quickly. And these are single 5 to 30 millisecond accelerations. And they did it both with the head immobilized, which produced only linear accelerations, and then without a collar on, which allowed the head to rotate, which produces angular accelerations. They used 3 different primate species with different brain sizes, and they established thresholds for concussion, subdural, and axonal injury for each of those 3 species of monkeys. And then what they did, and this is key, they extrapolated this to human brains, and particularly to, well, they didn't, but other people have extrapolated this to infant human brains based upon mass scaling, that is, the size of the brain. You can see the problem with that. This is a diagram showing this is sort of from the data showing the squirrel monkey, rhesus, and chimpanzee, and then they put man on here based solely on the size of man's brain. Tina Duhaime in 1978 was the first person to attempt to model human abusive shaking and impact using this, what she called a biofidelic doll model. It wasn't particularly biofidelic, but it was the best at the time. And she subjected these dolls to shaking, which is 100 to 250 millisecond event duration, and impact, which is about a 30 millisecond event duration. And she found basically that shaking alone didn't reach injury thresholds for subdural or traumatic axonal injury. In fact, it didn't even come close, but impact exceeded the thresholds for both. And there have been a number of subsequent models by Prang, which is the group, again, at Penn, by Carol Jenny, using the Japanese Aprika model, and there have been others with varying results. This is just, again, from Tina Duhaime's paper showing the triangles here are impacts, and you can see that they easily exceed the thresholds, many of them for traumatic axonal injury and subdurals. But here are the circles way down at the bottom are the angular acceleration, angular velocity for shaking. Doesn't even come close. So people have always asked, people have been saying, well, we can't achieve injury thresholds by shaking, and so shaking therefore is not injurious to the brain. The question we should be asking is not really, can we accurately measure the forces during forceful shaking? It's a qualified yes, depending on what kinds of model you use, and there are different neck models and so on. But the real question is, are injury thresholds derived from adult monkeys undergoing single accelerational events of 5 to 30 milliseconds duration even remotely applicable to infant brains that are undergoing repetitive oscillatory loads, angular accelerational loads during repetitive shaking? And of course, the answer to that is, who knows? And I think you can pick out the monkey from among these pictures. And so, that just points out there are a lot of differences between adult monkeys and baby humans, as we all know. This paper by Schicks in just this year is a great paper looking at the limitations of all of the different experimental studies, the biomechanical studies, the computer modeling studies, and so on. And I'll just summarize basically. There are a lot of interspecies differences, both in the anatomy and the mechanical properties of different species brains. Injury thresholds in these studies, when they've done these, have involved different loading conditions, right? Impact is very different than shaking. And a single higher load but briefer duration impulsive load, which is a contact injury, an impact injury, versus a repeated lower severity load, but over a longer duration, is a very different beast. Brain is a viscoelastic tissue, and viscoelastic tissues require time to return to their baseline after a load, and their injury tolerance to angular acceleration varies with the duration of the acceleration pulse. And the viscoelastic properties of brain and spine are also age dependent, as you might expect. Infant brains, we'll talk about the differences in just a minute, but they're very different than adult human brains. Most studies have not examined loads, impulsive loads done in the sagittal plane, for which the brain is more susceptible to injury. Cadaver tissues have been used, and of course, they have different biomechanical characteristics. They're not vascularized and so on, and they respond differently to impulsive loads. The results of computer models depend on the input conditions, garbage in, garbage out. I'm not saying that it's garbage they're using, but the problem is the biomechanical properties of infant brain and dura and so on are not well studied. And of course, all these studies are using really structural failure, the engineering term, structural failure, rather than functional failure thresholds, which might be much, much lower. And so they may be very, very much overestimating the tolerance of brain tissue to injury. And of course, we need to compare infants and adults. Infants, again, the viscoelastic properties of brain and cervical spine are both age dependent. Infant brain is 3 to 4 times less stiff than adult brain tissue. It has increased brain water content, less myelin. The skull has open sutures and an open fontanelle. The cervical spine is very different in an infant. The facet joints are flatter. The ligaments are much more stretchy, and so there's a lot more mobility. And the vertebral bodies are somewhat wedge-shaped. And the fulcrum of the neck stress is higher, that is, from the occiput down to about C3. So that occipito-cervical junction, this is going to become very important later in the talk, is much higher in infants and young children than it is in adults, where it's in the subaxial, mid-axial spine, cervical spine. Infants also have larger extra-axial CSF spaces. Now, this is a patient who has, we're going to talk about benign expansion of the subarachnoid spaces later in the talk as a mimic or a differential diagnostic consideration. So this is an exaggerated, but this is the same thing that happens in normal infants. There's more CSF around the brain, between the brain and the dura, and you can see the vessels crossing over this subarachnoid space. I'd like to talk about a couple of other differences. There is a lack of the traditional arachnoid or pachyonian granulations. There are more dural venous lakes, sinuses that have blood within the leaves of the dura in young children versus older, or infants versus older children and adults. And most importantly, there's an age-dependent metabolic response of the brain to injury, and I'll talk about that in just a second. So here's anatomy of the parasagittal meninges. You have the superior sagittal sinus, which you can see here, and there are a number of venous lacunae adjacent to the sinus that are within the leaves of the dura. The bridging veins, which is the thing that we're thought traditionally has ruptured as a cause of the subdural hemorrhage, you can see them here on this autopsy photo, and it's been injected, so these appear blue. Here, down here with the stars, are the pachyonian granulations, and we'll get a better picture of these in just a second. These used to be in these little holes in what are called venous lacunae within the dura. This is an electron micrograph of the arachnoid granulations. They have kind of a tennis head or tennis racket head on them, and they have a narrower neck. They project into the venous lacunae and the superior sagittal sinus, and they're responsible, of course, for transmitting CSF from the subarachnoid space into the venous system. And this is a diagrammatic representation of it as well. And this is another depiction of these arachnoid granulations inserted into between the leaves of the dura, where the CSF can then be transferred over to the venous system for reabsorption. The problem is that infants have arachnoid villi, which you kind of think of them as just being like your finger. They don't have that tennis racket head on the top of that villus. And so you can imagine that those villi that are stuck into the dural lacunae are much more readily and much more easily stripped from the dura. And in fact, Keith Aronik, one of my pediatric neurosurgical colleagues, and Fox have described this, saying that the arachnoid, which is normally adherent to the dura at these sites of the arachnoid granulations, in the infant, the dura is much more readily stripped away. The arachnoid is much more readily stripped away from the dura. So there's a big difference in the attachment strength of the arachnoid to the dura. And you can imagine that stripping that arachnoid and those villi away pulls them out of their moorings in the dura and leaves a tiny hole behind, which can bleed. The third thing is the difference between infants and adults is that the infants have these multiple venous lakes in the infant dura that tend to go away over time as the patient grows, or as the person grows. And these are most luxuriant in the posterior falx, the tentorium, and the posterior fossa, and they diminish with age. And here is an example. This is the brain's been removed. You see the brainstem here. This is the posterior falx and the tentorium here. And you can see, and again, an injected specimen showing that. And finally, I want to hit upon these age-dependent metabolic responses to injury. There are quantitative and qualitative differences between infants and adults. And I give two non-abusive head trauma examples of this. So the first is the quantitative differences, and that's cranial radiation, right? If we give cranial radiation to a 10-year-old, we can expect to see a certain drop in their IQ that's dependent on their age and the amount of radiation that's been given. And it's a fairly predictable relationship. So the younger you are, the higher our IQ drop. There are other things that are totally unexpected. And I give the example of eye patching. If we take an 8-year-old child or an adult and we put an eye patch on them for 6 weeks, nothing much happens. You take the eye patch off, they go back to what they were doing. But in an infant or a child under 7 years of age, you do that and you would get a pronounced visual loss, which is totally unexpected. And so these things represent what I call developmentally regulated processes they are due to synaptic plasticity. And in terms of the vision, it requires binocular input during a critical developmental period for appropriate visual development. How does that relate to abusive head trauma? Well, it turns out there are a number of studies, primarily done by the people at Pittsburgh, that have shown that there is an age-dependent and to some extent a mechanism-dependent response to traumatic brain injury. And these involve a number of metabolic markers, for excitotoxicity, brain ischemia, inflammation, oxidative stress and free radical damage, and apoptosis. Those are the five different categories. And you can see in the table on the right, there is a dramatic change. For example, in glutamate, there's a 7-fold increase in glutamate in the CSF of patients following traumatic brain injury compared with accidental injury. Glutamate is an excitotoxic neurotoxin in high doses. This may be age or mechanism dependent because, of course, accidentally injured children are generally older than abused children, infants. And so it may be a combination of age and or mechanism. And the functional thresholds for triggering these metabolic cascades really have not been worked out. And then I want to just finally talk about what I call the evidence for shaking, and that's perpetrator confessions. We have a number of papers that have described perpetrator confessions, and they describe shaking as a common mechanism of injury. And when we look at those children, they have an identical pattern of injuries compared with the cases lacking a confession. They're very, very similar. And the clinical presentation, the injury pattern, and the outcomes are similar, whether or not impact was described in these confessed cases. And it's a pattern that we essentially, or virtually, never see following even severe and violent accidental injuries with obvious impact. And this is from Starling's paper. And I'll point out that if you look at, these are all perpetrator confessions. If you look at impact, shaking only, or both, you see that subdurals are present in roughly the same proportion. Retinal hemorrhages, again, roughly the same proportion, maybe a little bit higher in the combination, the admitted combination. But look at the skull fracture and scalp swelling, which are indicia of impact injury. You can see that they are very different. First of all, they're only described or seen, in the confessed impact cases, only about 40% for skull fracture and 20% for scalp swelling. So that tells me that you can have impact without evidence of impact, and there are other studies that suggest this as well. And then people who admit to shaking, some of them obviously have impact and they're lying, but it's a fairly low number in this study. And again, for shaking plus impact. But the point is that we're seeing subdural and retinal hemorrhages, the same intracranial and retinal injuries, whether impact or shaking or both are described. This is from Vincent's paper. It's a prospective study of 45 confessed abusive head trauma cases in France where there's no plea bargaining versus 39 publicly witnessed accidental injuries. And among these cases, all of these things were more common in abusive head trauma. They had a greater incidence of increased intracranial pressure, seizures, coma, subdural hemorrhage, mixed subdural hemorrhage, ischemic brain injury, retinal hemorrhages, 85% versus 15%, mortality, 22% versus 5%, and an increase in extracranial fractures. But again, impact injury is less common among the abusive head trauma cohort compared with the witness accidental traumatic brain injury. And this is just a table from their paper. And what's interesting is this here at the bottom. They're looking at the sensitivity, specificity, and positive and negative predictive values. If you have a subdural plus retinal hemorrhage and no scalp swelling, the positive predictive value in that study was 1. It's kind of amazing. So if shaking alone can't achieve injury thresholds, then all perpetrators must be consistently and universally lying about the same phenomenon. That just defies logic. I don't understand how you can continue to say that shaking can't cause injury. Now, I want to focus a little bit on neck injuries, which is a more recent phenomenon. And that is, there are a number of post-mortem studies in fatal cases that detected injuries at the cervicomedullary junction and the upper spinal cord and the upper cervical nerve roots. So a very high cervical region. And this is just a list of them here. We did a study looking at MRI scans in cervical and looking for cervical ligamentous injuries in children. And specifically, we used this STIR MRI imaging sequence, this short tau inversion recovery MRI sequence, which is very sensitive for looking at ligamentous injury. And we had 3 cohorts, an abusive head trauma cohort, among whom 78, nearly 80% of them, had evidence of ligamentous injury. Among the second group, 43% of accidentally injured children with clinical suspicion of spinal injury. So this is a highly select group. 43% of those had evidence of spinal injury. And then we had a non-trauma cohort, only 1 case of which had ligamentous injury, and that was a child with septicemia and multiple prolonged seizures. So this is a normal MRI scan. This is an anatomical picture here, and you can see this is the nuchal ligament, which is a midline ligament that joins the occiput with all the spinous processes of the cervical vertebrae. And that nuchal ligament is seen here on T1 weighted images. You can see the kind of marbled appearance here because it has some fat in it. T2 weighted images, here it is. Here it has a lamellar component and a deeper component. And then the stirrer, where everything is dark. So note that everything here is dark. So if you see bright on a stir image, it's an injured ligament. So here's just a bunch of examples from our study. You can see white here on both sides of the lamellar component. There's another one on the outside of the lamellar component, as well as in the deeper component. And again, all very, very similar. This one's been partially torn. And what we found were significant correlations between these cervical ligamentous injuries and the presence of brain ischemic anoxic injury. And you can see here the nuchal ligament and other ligaments with very highly significantly, statistically significant. We also looked at subdural hemorrhage. That's present in about half of children. This is spinal subdural hemorrhage. About half of children, 44% of them are visible on cervical imaging, but 56% of them did not extend up into the cervical spine and were visible only if you got thoracolumbar imaging. The spinal subdural is similar in intensity on the MRI to the posterior fossa subdurals. You can see that in these two pictures here. Here's the spinal subdural down in the thoracic region. Here's the posterior fossa subdural, again here and down here. There are no subdural veins in the spine, and there is no evidence of direct caudal spinal injury. So our conclusion from this is that these subdurals in the spinal canal probably are drop down of hemorrhage that began in the head and then dropped down into the spinal subdural space. And there have been a number of other studies subsequently that have confirmed these findings. And so this leads to a new paradigm for brain injury and abusive head trauma. And that is that I believe that the primary traumatic axonal injury is at the cervical medullary junction. That leads to disordered breathing, which we know occurs. Apnea and disordered breathing are very common in children with abusive head injury. And that in turn leads to a secondary ischemic axonal or brain injury. And of course, the metabolic responses that we talked about a few minutes ago may also add to those injuries. And this is supported by the fact that children with abusive head traumas have very frequent, early, within the first 24 to 72 hours, and very difficult to control seizures, often requiring 2 anticonvulsant medications. Interestingly, that's the same pattern that we see following things like near drowning and other forms of ischemic, anoxic encephalopathy. But we don't see that pattern following accidental traumatic brain injury. It's very, very, very uncommon for me to see an accidentally injured child who has persistent multiple seizures that are difficult to control. And I think that really speaks to the underlying pathophysiology of abusive head trauma. Here has shown that apnea has a 93% positive predictive value for abusive head trauma with an odds ratio of 17.6. So multiple lines of evidence suggesting this ischemic anoxic injury. So let's shift gears here and talk about the differential diagnosis of abusive head trauma. How much overlap is there between abusive head trauma and its mimics? Some people would say that there's very little overlap, and most cases are very relatively easy to discern. Other people might look at it this way and say that, well, gee, you can't differentiate these two from them, differentiate AHT from its mimics in many, many cases. So let's start with short falls, because that's the most common problem we face. There are multiple comparative studies that have compared abusive and non-abusive or accidental injuries, including in those studies many, many children with falls. And I just listed a bunch of them here. And if you look at them in toto, subdural and retinal hemorrhages are much more common in abusive head trauma, as we said at the beginning. Both of them are highly statistically significant, especially retinal hemorrhages that extend out to the periphery, that cover the macula, are subretinal and have retinoschisis. And then skull fractures, subarachnoid hemorrhage, cerebral contusions, about the same between abusive and non-abusive head injuries. And epidural hematomas, even when they're large and cause coma, are more commonly seen in accidental injuries. So I'm going to go through a bunch of slides here just to tell you, this is Carol Jenny's favorite part, what the neurosurgeon sees. This is from about 18 months of my clinical practice, and I didn't cherry pick these. I just went through and looked at all the trauma that I saw. So I'm just going to go real rapid fire through this. I think you'll get the point. So this first child fell to the floor from grandma's arms onto his head. He had a cephalohematoma here. He had a skull fracture, no intracranial injury. Mom slipped on ice while carrying the baby. The baby fell onto the road. Cephalohematoma, parietal skull fracture, no intracranial injury. Mom tripped over the bed. Baby fell from her arms to the floor. Cephalohematoma, parietal skull fracture, no intracranial injury. This child fell from dad's shoulders to the floor and had a depressed skull fracture and no intracranial injury. Fell from mom's arms to a linoleum floor, had a cephalohematoma and a parietal fracture, tiny little subpeel subarachnoid hemorrhage there. Dropped from arms during a domestic dispute, cephalohematoma, parietal skull fracture, a small epidural hematoma there. Pulled off a bed by a sibling onto the floor, cephalohematoma, parietal fracture, tiny epidural hematoma there. Fell from a crib onto the floor, frontal fracture, no intracranial injury. Fell in a bouncy seat from the counter in the kitchen onto the kitchen floor, cephalohematoma, parietal skull fracture, no intracranial injury. Fell in a bouncy seat from the kitchen counter onto the floor, different case, cephalohematoma, parietal skull fracture, tiny little epidural hematoma there. Fell from a bar stool, not in a bar, to the kitchen floor, cephalohematoma, parietal skull fracture, tiny little bit of subarachnoid hemorrhage in the sylvian fissure. Fall down 7 carpeted steps, cephalohematoma, parietal skull fracture, tiny little epidural hematoma there. Fall down 12 stairs, cephalohematoma, basilar skull fracture, small posterior fossa epidural with a little tiny bit of air from a basilar skull fracture. Fell down 3 steps to a brick patio, cephalohematoma, parietal skull fracture, tiny convexity subdural hemorrhage there. Fell 13 feet through a barn hay hole onto packed earth. This is a common injury in central Pennsylvania. Cephalohematoma, occipital skull fracture, and a tiny underlying epidural hematoma. Restrained passenger in a T-bone motor vehicle crash, cephalohematoma, parietal skull fracture, no intracranial injury. Fell from a car onto concrete sidewalk, cephalohematoma, rather large, parietal skull fracture, moderate epidural hematoma, and mixed density, blood under the scalp here as well. This is a child with macrocephaly and what's called benign expansion to the subarachnoid spaces, or BESS, also called benign external hydrocephalus. I was following this child pre-injury and had these enlarged subarachnoid spaces. They fell down 14 carpeted stairs and had a new posterior interhemispheric tentorial subdural, no retinal hemorrhages, no cephalohematoma. But we're going to talk about BESS in just a minute. 8-month-old pulled himself over the crib rails and fell onto a tiled floor. He is found comatose, coagulopathic, and hypotensive, has a rather large cephalohematoma, parietal skull fracture, mixed density subdural hematoma, parenchymal contusions, and hypodensities involving the brain. He had no retinal hemorrhages, and his skeletal survey was otherwise negative. Now, this is one where you kind of go, well, I'm not sure, right? This is very unusual if you compare it to the other, 20 or so cases I've shown you. He also, though, had upper cervical prevertebral edema, and he had vertebral body edema involving T5 to T9. And so we felt with this combination of injuries is almost certainly this is an abusive head injury. And this child here began screaming spontaneously, stiffened, extends his arms and hands, and had disordered breathing. On admission, he's comatose, apneic, bradycardic, required intubation. He has diffuse left-sided subdural hematoma, got a lot of hypodensity in the brain here, subtle, but and no cephalohematoma. And here's his MRI scan showing the subdural blood very nicely on this sequence. And this child required urgent craniotomy, had 16 healing rib fractures. He had extensive retinal hemorrhages, multiple layers extending to the ora serrata. This figure is not from this child, I just want to point out. It's similar to his retina exam. So this is a child who clearly has abusive head trauma. And I don't think there's a big issue with comparing any of those other cases with that last case. When you compare the vast majority of household accidental falls with abusive head trauma. And just from the literature, I'll just review a couple of cases. This is a review of 26 studies that I did of accidental falls. There were serious or life-threatening injuries other than epidural hematomas were extremely common in falls less than 4 feet. The odds of dying in the aggregate were 23 out of 1902. Of those, 18 fell greater than 3 stories. These are not just short falls in this study. And so if you exclude those, the risk of fatality otherwise is 5 out of 1884, which is about 0.25%. Most of the injuries include skull fractures, epidural hemorrhage, subarachnoid, small contusions. Small subdural hematomas are rare, but they do occur in accidental injury. They're generally limited, focal, and underlying a skull fracture or an area of soft tissue swelling. This is from John Plunkett's paper, which he uses to support his contention that you can die from a short fall. And I'll just go through the paper here. Over 75,000 reports of playground equipment, so this is not falls in the house, injuries reported to the U.S. Consumer Product Safety Commission. Out of those, there were 18 deaths. 5 children were less than 2 years of age. That's a raw incidence of less than 0.024%. He uses that to demonstrate that children can die from short falls. I would interpret from this that it is extraordinarily rare. Interestingly, 3 of the children, one child had thrombocytopenia, and one had a cerebral AVM underlying, so had underlying conditions that might have predisposed to them dying. And one patient actually died later from a carotid dissection from a little bit of a neck injury and had a stroke and died. So really didn't die from his injury, from the impact itself. If we look at witness shortfalls, most of these are in the hospital, and there are a number of studies. I summed them all up. There are over 800 children. They fall from the bed, chair, crib, parents' arms. 8 of them had skull fractures, which is less than 1%. One caveat is that radiologic imaging was not performed in most of those patients because they were neurologically and in every other way intact. And so people didn't even bother getting a skull x-ray on them. And there were no neurological problems or deaths. Chadwick's paper's been significantly quoted, a review of 25 studies looking at daycare centers. These are daycare centers, not single people looking after infants in their home. These are certified daycare centers with line of sight visibility, multiple providers. The caretakers are not isolated with the child. There's always somebody to witness. And he looked at all the fall-related deaths. He found 2 fall-related deaths among more than 6 million children in daycare 0 to 5 years of age. The adjusted risk of fall-related death in a daycare he estimated is less than 1 in a million children per year. And he noted that there's no peer-reviewed report of a fall-related death in a licensed daycare facility. And this is one of the most recent studies. This is from Mulligan in 2017. And this is 106 children who fell, all of them under a year of age, about a quarter of them from a bed or a sofa, 21% from some sort of baby equipment, a walker or a swing, changing table. 16% were dropped by an adult and 5% went downstairs. Out of the entire group, 12% were admitted and 8% were admitted to the PICU. Among those who were admitted, about half of them were admitted with isolated skull fractures. About 30%, though, had skull fractures with some sort of intracranial injury, really not very well specified in terms of their presentation and how sick they were. And 9% had an isolated intracranial injury. And so these are the breakdown of the intracranial injuries. You can see half of them were epidural hematomas. About a quarter had subdural hematomas. Again, it's not clear how big, where, and so on. 20% had subarachnoid hemorrhage, 7 had intracerebral hemorrhage, and 10% had contusions. A few of the patients had more than 1 lesion, so this adds up to more than 100%. There are a few situations where there's an increased risk of injury from falls, and those are basically 4. There's increased risk, and I don't know I don't know offhand the relative or the odds ratios, but people who are, or infants who are dropped from somebody's arms, infants who fall downstairs, infants who are on walkers and fall downstairs, and then occipital impacts. This is a highly select case from the Helfer Society. They queried all the Helfer members, and they were identified. They actually identified 23 cases, but only 8 cases submitted information about these. But these were occipital impacts where the infant fell back and struck the back of their head. And you can see that 75% of them had subdurals. Two of the five who had imaging with MRI had brain infarctions. Retinal hemorrhages were present in 7 of the 8, but no child had retinoschisis. They did have 1 death. All of the others had returned to baseline by the time of discharge. So occipital impacts where the child can't break their fall. And there's also probably a rotational component as their head comes back and smacks the floor. And all these were hard surfaces, by the way. Might be more injurious and more likely to have retinal hemorrhages. The other issue is, how do children die after falls? I think that the mechanism of death is very important. This paper by Hall was an autopsy study of 44 children who died from falls. 18 of those suffered short falls of less than 3 feet. All of them died from lethal head injuries. 100% had skull fractures. But look at the highlighted areas. 3/4 of these children died from surgical mass lesions. These had large epidural or subdural hemorrhages that required surgery. And the findings and the circumstances, the remaining 4 children are not specified among those. So at least 3/4 of these children who die after falls, they die from an expanding mass lesion. Very important. Children who die of abusive head trauma most commonly have tiny little smear subdurals, and they die from their underlying brain injury. Their subdural is simply a marker, but is not the lethal pathology. And then this paper by Reiber, 19 cases of lethal short falls, less than 6 feet, 3/4 of whom had clear evidence of homicide. And they found only 2 genuinely accidental falls with death among these cases. A 21-month-old who fell 5 to 6 feet from a top bunk and had subdural hemorrhage and edema, and a 17-month-old who fell backward 2 to 3 feet from a rocking chair with subdural, subarachnoid, and parietal contusions. And both of these children went on to die. So, and none of these cases were witnessed, so the history may or may not be correct. So very uncommon to find lethality from short falls, especially those in which there are not mass effect, large surgical subdurals. And I'll leave you with this, just in terms of the accidental trauma, this paper by Benoit. These are falling from a 2nd story or greater window. And this is their series, and then they looked at the National Pediatric Trauma Registry, and note that the mortality is somewhere between 2 and 4%. So compare that with the reported abusive head trauma mortality, which is somewhere around 25% mortality. Abusive head trauma is apparently considerably worse than falling from even a 2nd story window. Birth trauma, the incidence of intracranial hemorrhage varies. There are 3 classic studies. You can see it varies from 6 to 46%. It's higher after vaginal versus C-section. All of these are gone within 3 months, and 94% are gone within 1 month. No complications. They have 1 new asymptomatic subdural hemorrhage that bled at 2 weeks follow-up. Birth-related retinal hemorrhages, we know, are fairly common, about 40% on average. They're more common following spontaneous vaginal delivery and assisted deliveries. They're almost always posterior pole and almost always intraretinal. No associated brain injuries, and most of them, virtually all of them, resolve by 6 weeks postnatal. I'm going to talk very quickly about benign expansion of the subarachnoid spaces, which is an entity. As you can see, the classic head acceleration here over the first 18 to 24 months. These are children that present with macrocephaly. About 60% are males. Positive family history in about 40%. And again, this classic curve. This is the typical pattern where you see increased CSF spaces around the outside of the brain. On an MRI scan, you see the vessels crossing over that subarachnoid space, which is iso-intense to CSF throughout. And this, again, I showed this before, but these are the vessels crossing over that expanded subarachnoid space. We now know that about 2% of cases of benign expansion of this, from these two studies here, have overlying or associated small asymptomatic subdurals with minor or even no reported trauma. Macrocrania is a clinical feature in most of those. They're asymptomatic otherwise, except one child I saw who had an isolated seizure. There's one reported case of BES with retinal hemorrhages in a child who fell from a standing position. And again, these are chronic subdural, they can also present as chronic subdurals overlying an expanded subarachnoid space. It may be difficult to exclude chronic abuse in these cases because they can look very similar. Here's an example of that. Here's the subdural here overlying an expanded subarachnoid case, in this case, or space, in this case with mild ventricular enlargement as well. Here's MRI scans showing that subdural hemorrhage here overlying the subarachnoid. This is a very incomplete list of other rare mimics, and I would refer you to Steve Boos and my chapter in the current edition of Child Abuse, Medical Diagnosis and Management from the AAP. But genetic and metabolic conditions such as glutaric aciduria, Menkes-Toothie hair disease, Ehlers-Danlos, osteogenesis imperfecta, coagulopathy, particularly delayed hemorrhagic disease of the newborn, aneurysms and vascular malformations, usually pretty easy to identify, and certain infections like meningitis, herpes encephalitis in particular. I'm going to finish up with a couple of conspiracy theories. This is the hypoxia-induced subdural hemorrhage of Getty's. This is dura from 50 fetuses and infants. Notice that most of them were very, very either prenatal or very early on in infancy. Only 9 deaths in between 1 month and 1 year of age, which would be the age range where you would see abusive head trauma. And they had microscopic intradural hemorrhage or microscopic blood subjacent to the dura. None of them had macroscopic subdural hemorrhages. They were most commonly seen in the preterm and neonatal deaths. Only 2 of the 14 older infants had the hemorrhages. The brain weights were normal in all but 1 case, so suggesting no cerebral edema and no statistical relationship between, which, by the way, cerebral edema, which you would expect from hypoxic injury, and no statistical relationship between the hemorrhage and hypoxia. But despite this, she hypothesized that hypoxia in non-traumatic conditions might cause subdural hemorrhage from leaky vessels, a combination of hypoxia, raised ICP, and brain edema without the necessity for trauma. And she hypothesized with no evidence that retinal hemorrhages could occur from a similar mechanism. This was roundly criticized by multiple people, and I would draw your attention to this paper in Pediatric Rehab Medicine by Hunt, which goes into great detail about all of the issues. Getty's actually admitted her hypothesis was never meant to be used in court. And there have been multiple other studies that have looked at hypoxic ischemic injury looking for subdural or retinal hemorrhages, and they're extraordinarily rare, to say the least. Catastrophic rebleeding. This has been promulgated by a guy by the name of Yushinsky, who's a neurosurgeon. And basically it goes like this. Subdural hemorrhage can occur after minor or unrecognized trauma or even from birth injury, burping, bouncing a baby on the knee, maybe a short fall, prior birth trauma. You know that birth trauma or birth subdurals are very common and may remain occult for months. He then says that subdurals rebleed and that subdural bleeding expands over time and ultimately causes a sudden catastrophic collapse, coma, or death. He could provide no peer-reviewed case to support this theory. When I brought him to the AANS Professional Conduct Committee, he was censured by the committee for irresponsible medical witness testimony. And I'm going to finish with this dysphagic choking article, a single case report having 4 authors. All of them, it turns out, were not treating physicians. They were all expert medical testimony, medical experts that testified in the case for the defense. The story was that the father left his 4.5-month-old infant with a bottle propped on the infant's chest and returned to find the infant blue. They say that his father provided consistent history throughout the entire investigation. He had a prolonged CPR, a pH of 6.7 on admission. He was clearly in DIC, and he had subdural, subarachnoid, hypoxic injury to his brain, and retinal hemorrhages. And they reported that he had fresh posterolateral rib fractures involving the fifth and sixth ribs, which they thought was from CPR. The authors, unfortunately, didn't disclose that none of them were the treating physicians. There was an additional healing rib fracture in this child. The father's initial account did not describe choking, but only appeared later. And they also failed to put in the report that the father was found guilty and his verdict was upheld on appeal. The journal editor, the physicians, treating physicians and the prosecuting attorney in the case sent a letter to the editor of the journal, and this was part of the response they got from this is a quote from the journal editor. This does not require that all the facts be presented or even that the presentation stick to the facts of the case at all, as it represents primarily a vehicle for the presentation of the alternative theory. So I guess you can have alternative facts, even in medicine. And I will just, 2 slides here, just to mention the Swedish, what's called the SBU report. I'm not going to describe it in any detail. You're certainly welcome to read it. There is a very, nice article by DeBell, I guess, that really goes through the SBU report in detail and points out all the flaws. But this is being used for defense in a lot of cases throughout the world to try and get people off from reports of abusive head trauma. So I will stop there, and we have probably 1 minute left, or 3 minutes left for questions.
Thank you so much, Dr. Diaz. And indeed, we do have 3 minutes for questions. While I let people formulate their questions if they have them, I just wanted to put a plug in for our Grand Rounds by WebEx that's going to be next week. We had a little bit of a change of schedule on purpose because we were able to recruit Edwin Lindo from UW to speak about racism in medicine next week. And so he will be speaking a week from today for Grand Rounds, and thanks to Dr. Cora Bruner, who was scheduled for that day and has agreed to move her talk to August. She will still be speaking, but just a little bit later. So this is just a plug to tune in next week for Edwin Lindo. He's one of the founders of White Coats for Black Lives, and it should be a really interesting talk. And now with 2 minutes left, I'll see if anybody has questions. I did see a comment from Dr. Feldman. Through our professional society, the Helfer Society, I'm collecting about 6 to 8 independently witnessed shaking events which caused concussion with or without radiologic changes of AHT. Thank you so much, everyone, for being here. Thank you, Dr. Diaz, for this really interesting and informative talk and amazing use of the 100 slides that you had. And we'll see everybody next week. Thanks so much, everybody.